Hi class, my name is Coda Brinker, and this is my presentation on substance use. So the substance I chose to do my presentation on is fentanyl. I kind of hit on xylazine as well as fentanyl just because of the amount of patients we're seeing who are having side effects from xylazine who are on fentanyl. Um, Really big in Pennsylvania and the clinic that I'm working in right now. So I thought I would just kind of touch on that as well. So fentanyl is a mu receptor opioid agonist that is 50 to 100 times more potent than morphine. In the ICU setting where I work now, we use fentanyl post-surgery to treat the patient's pain. They're often on a PCA and then transitioned to oxycodone a few days after surgery. Xylazine is an alpha-2 adrenergic receptor agonist. Not really used for human consumption or use. It's often used as a veterinary tranquilizer. Between the years of 2019 and 2021, there have been 107,735 deaths related to fentanyl. In the CDC and US Drug Enforcement Administration identified as a significant threat to public health, that being the epidemic with opiates or fentanyl in this case. Um, so a little bit about the abuse. So fentanyl was first developed in 1959. It was started to be used as an IV analgesic in the 1960. Um, Between the years of 2011 and 2018, there was a market increase in fatal overdoses of fentanyl. Tranq is relatively new to the game in terms of being cut with Tranq or the xylazine. Um, Fentanyl is very versatile. There are a number of ways that it can be used or abused. A lot of times you think fentanyl injection, that's how we would use it in the ICU. But it can also be converted into powder, snorted, smoked, taken orally, or there's even dermal patches, which can be abused as well. Tranquilizers were first introduced in the 1950s. But in terms of where we're at now in the epidemic against opiates, there's been a large increase in the number of xylazine related deaths mixed with fentanyl from 2015 to 2022. Prevalence and epidemiology in the US. So fentanyl overdoses in the United States have increased tenfold from 2010 to 2017. You see the numbers here. There was only 3,007 deaths in 2010 to 28,466 in 2017. Um, So, what do they think is causing this epidemic of fentanyl? Medical mismanagement. There was a lot of providers who were overprescribing opiates, putting that on the streets. People liked the feeling they would get when they were on these medications, and then they would seek it out. Um, and when they couldn't get it from a provider, they would go to a different way to get the drug. So heroin, we're going from buying pills off the streets, buying people's prescriptions, et cetera, et cetera. And then social and economic factors have been huge contributors to the growth of the opiate epidemic. We'll talk about this later in the presentation, but lower income houses. I even have a slide in here of a video from Kensington, Pennsylvania. It is rampant with tranq and fentanyl, and it's really sad to see how much it's affected the community. So risk factors for vulnerable populations, younger adults 18 to 25, higher risk of misuse, while older adults have a higher risk of negative effects from using fentanyl. Um, More likely to have the sedation side effects, things like that. Patients with pre-existing mental health conditions, patients with history of previous substance abuse. If there is a patient that you know has abused substances before, you're not going to actively give them more medications that can be abused. Homelessness, people turn or begin using substances and become homeless. And then patients with a family history of substance abuse, it is a mental health condition, addiction to the opiates. It's passed down from generation to generation. Where if there is a underlying familial history of drug abuse, you want to be cautious. So short-term and long-term side effects of fentanyl and trank. So short term, it's euphoria. That's why they're doing it. They like the feeling. They're getting high. They're getting um, forgetting about what they want to forget about. Drowsiness, nausea comes really big with fentanyl. We see that in the ICU. A lot of the times we give fentanyl with antiemetics such as Zofran because it can cause some nausea and vomiting, confusion, sedation. When you're taking fentanyl, you get constricted pupils, and when you're withdrawing from fentanyl, you'll have um, dilated pupils. Respiratory depression. We watch this a lot in the ICU. You're giving patients opiates, you're making sure that they're still breathing, or you'll have to use Narcan to reverse the effects. Slurred speech, impaired judgment, and then I went ahead and said skin abnormalities, mostly for the patients that are injecting. This is huge in trank. You see, it's eating away at their skin. It's very disconcerting to see. And then long term, obviously, dependence, opioid addiction is a real thing, amnesia, depression, anxiety, and then more like metabolic effects here. Like you can go into liver failure, bloodstream infections if you're using injections. We have a lot of patients who are getting valve replacements because they're using needles that aren't clean and they're getting like septic emboli that are breaking off from sites in their body and going into their heart. This is a video. I'm not sure if it's gonna work, but I'm gonna try here. All right, I don't know if it's going to work, but if you have a chance and you want to see follow this post, it's just people go through and you see these people who are like crouched over and leaning and um they're homeless and it's really sad to see like how this epidemic has affected people who had seemingly normal lives. So signs and symptoms of abuse upon assessment. So you're not gonna chances are if they're coming to see you, they want to get off of fentanyl. They're not going to come in while they're actively using. So you're not going to see those immediate effects, but there's things to look for when you are assessing your patient. Look for any active prescriptions for opiates or fentanyl. If they have access to it, the chances of them abusing it and becoming addicted are much higher. But you'll see like withdrawing from activities such as work, school, or daily activities. The dope kind of takes over your entire life. And going off that, poor performance at school or work, like not putting in the time, not being as productive or as effective in your role in those situations. Neglecting personal relationships. You are in a relationship with the fentanyl. You don't have time for anything else. That's all you're thinking about. You're trying to get back to the drug. Financial strain, it costs money. Um, we've had a lot of patients who were really successful and got addicted and spent all their money, and then they couldn't pay their mortgage, and, and they lost their jobs, and now they don't have anything. Um, Signs of withdrawal if they haven't been able to get their last high. So just making sure you're looking for things like that can be dangerous. There are medications you can prescribe if your patients are trying to go through that on their own. Um, and then criminal behavior. If you don't have the way to get money to get the drugs, then um, sometimes they often turn to acts of crime. Is there a potential for overdose or use as suicide weapon of choice? Fentanyl has a very high potential for overdose. A lot of pharmacies you can actually get Narcan or naloxone over the counter. I think there are some places that will give it out for free. It's a reversal agent. I myself have walked through the city and have seen people overdose with EMS um, on the street next to them. So very, very high potential. And then with the trank, you're potentiating the effects of your fentanyl even more. So over 150 people die a day from fentanyl overdoses. I think that just goes to show you it's very serious. As far as a suicidal weapon of choice, I don't think that's people's goal when they're using heroin. They're trying to get high and a lot of the times it is an accidental overdose. So as far as the care plan, first and foremost, I think the want to stop is necessary. If your patients are coming to see you to get off of opiates, then they're wanting a change in their life. And I think you're not going to be able to help anyone that doesn't want to stop. So as far as that goes, medications such as methadone or Suboxone are used to transition off fentanyl from the streets. Um, so Suboxone is a mix of buprenorphine and naloxone, and the naloxone is inhibiting the full effects of fentanyl. So it's hard to abuse. So that's helping them avoid dope sickness, so they're not or withdrawal, so they're not going cold turkey. You can use Suboxone long term. A lot of the patients I see have been on it for quite some time, and they're active members of society. They're doing great. It's really awesome to see how quick someone can turn around. So you can use the Suboxone to help wean them off altogether. Some people will start on a higher dose and slowly taper it off until their cravings kind of go away. Another option is long-acting injectables such as Sublocade, or actually there's a new drug called Brixada. It's a little bit more versatile. It doesn't have to go into the stomach. There's like more of varied doses, so you can go weekly or you can go monthly. But it's a pretty cool new drug. So those are subcutaneous injections, and they stay in the system longer. It's easier to transition off your Suboxone because you're not taking it every day and it lingers in the fat tissues. So it kind of helps to keep the cravings at bay. Sublocade can last for quite some time in your system after you've gotten it. So you still actually might test positive on a drug test for buprenorphine, which is what they are. So Sublocade is Suboxone, but without the naloxone. So it's pure buprenorphine. Um, so cognitive behavioral health therapy can also be used. I alone it can be effective. I think using it in as a conjunctive therapy would probably be best, making sure they're doing it for themselves and that they really want to get better, and that you can kind of maybe alter the way their thinking is about it, and just make sure they're staying on course. So there are people who don't want to go to rehab or intensive outpatient programs, but those are some options too. Referrals can be made for those. And then as far as following up for these patients, a lot of them are not financially well off. They're getting off fentanyl, they're getting reacclimated to society, being employed. So they'll come weekly to get their dosing, and then they'll come back every week to make sure um, that they're staying clean. They'll be given drug tests. You want to make sure there's not any other things in their urine that they are prescribed, and then making sure that they're doing well, making sure that the dosing that they're on is appropriate for them. But it's a very patient specific process. You have to listen to your patient. If they feel like they're craving, then they might need a little bit more, and that's okay. But as long as you're working toward the goal of getting them to where they want to be, and if they want to start weaning off, a lot of patients don't want to be on Suboxone forever. So they start and then they'll slowly start tapering it, and they'll be taking like half of their films or pills, and then um, some of them just altogether can get off, and they're very successful in doing so. So conclusion, with the increase of opioid prescriptions in the 90s, we created a huge, huge problem for ourselves in the form of an epidemic of opioid abuse. I see it daily living in big cities, especially like Kensington. It's a really sad sight. So with additions such as trying to cut the fentanyl and other things, the mortality is higher than ever. And since 2010, we've seen a skyrocket in the number of deaths. But the good news is there are treatment plans to help get patients off fentanyl and eventually all forms of opiates, and they're safe and they work. And I've seen firsthand just how quickly someone can turn their life around. um, and how effectively and live very normal, very happy lives. Caveat to that, there are not enough providers that can offer these treatments in areas where they need them. We can have a ton of providers in big city locations, and that's great because there are a lot of people suffering from addiction in those areas, but there are a lot of underserved populations out there that aren't being able to be reached. And I think by increasing the number of mental health care providers, we can definitely start working towards getting this epidemic under control. But it is going to be a process, and everyone kind of has to work together to do it. So here are my references for my presentation, and thank you so much.